with that, we're going to be presenting today our second webinar on vaping prevention, prevalence, adverse behavioral health effects, and prevention practices. And today's presentation is going to be focusing on vaping and adolescent behavioral health, understanding the relationship between the two. Go ahead, Dr. Shayton, and please take over.
Thank you very much. Just with a disclaimer that of the funding, which is for the Mountain Plain Prevention Center, and I'm really happy to be here and excited. Thank you for inviting me to speak. I have to admit that my talk, I narrowed down the topic a little bit. We can talk a little bit about some of the sort of larger impacts of vaping and behavioral health, but most to keep this evidence-based, focus it primarily about smoking and tobacco use, or generally nicotine and mental illness, and looking at the relationship between the two. This is, for me, this is one of the most important areas in tobacco research, and one that is sort of well acknowledged, but also sort of not understudied, I think, and underpromoted. Although with the emergence of vaping, I think it's become more important that we understand how nicotine, in particular, affects mental health and generally behavioral health among both adolescents and people who smoke in general. We've known for a long time that there is a strong relationship between nicotine use and mental illness, and this slide shows the results from a study in the US, kind of from 25 years ago now. But the results essentially hold true still, that smoking is just more common among people with mental illness. So for a whole range of conditions, this is, and conditions that aren't even limited to the ones here, ranging from a ratio of number of current smokers who have the condition compared to those without the condition, of about 1.4 for social phobia, to 2 for depression or PTSD, and up to 3 for people who have a substance use disorder. So we know that there is a strong relationship, and this has been shown over and over again. This a higher percentage of people who smoke have mental illness. A higher percentage of people with mental illness smoke. And the question is, why? So why do we see this relationship? And it's a complicated problem, and there are, and you know, the short answer, a very short answer, is that we're not entirely sure. But there are a number of sort of major theories that we'll talk about today about what the potential for the reasons behind this relationship is. The first possible cause of this relationship can be sort of categorized broadly under this heading of self-medication. That is, individuals with mental illness or with poor behavioral health are essentially self-medicating to improve their affective and cognitive symptoms. That is, nicotine might improve their mood. It may help them concentrate, may generally help people feel better and less stressed. And using nicotine, either in the form of tobacco or in the form of vaping, may be the reason that we see this association. Another explanation, though, is that there are common factors associated with both mental illness and nicotine use that cause both. That these socially related factors in particular that are common to both mental illness and smoking or nicotine use, such as peer modeling or poverty, stress, availability, and other issues are surrounding how, basically the social determinants of health broadly, that can cause both people to start smoking or use nicotine and may have an effect on mental health. So that this is really a situation of confounding, is the suggestion from this theory, that there is no true sort of biological relationship between nicotine use and mental illness, but it's confounded by this other factor. So there's a true other cause that that is common to both. Another sort of broad theory is a sort of a causal biological one. And this is where nicotine or smoking actually causes mental illness, that there is something about the drug itself that damages essentially the brain or and aspects of the brain that causes disease, the same way that nicotine use or smoking causes disease in other aspects of the body. So I'm going to go through sort of the evidence for each of these theories, starting with the idea of self-medication. And this is, I think, a really important one to understand because it's supported by just vast amounts of anecdotal evidence. The most reported reason people vape or smoke is to address stress, to improve mood, or generally to address the sort of the features that can maybe associated with sort of the self-medication hypothesis. They're smoking to feel better. And many people report either starting smoking to have done this or to continue smoking because of this. I found this on Reddit a little while ago, and it was a discussion about so people who in the smoking section on Reddit, and the question was asked: so people who started smoking because stress, anxiety, or depression, did it help? Was the question. And the plurality of people reported that yes, it did. So not only are people saying that they started or tried to use nicotine or tobacco because of in order for self-medication and to improve their aspects of mental health, but there actually many people are reporting that it worked, that it is helping them, that it did help them. This is a quote from one person: it did. Yes, in my case, it's helped me with my depression and anxiety. I felt really bad those months and I started to smoke and I noticed that I felt good again. Maybe it's not the best solution, but it helps a lot. And I really enjoy smoking. And this aspect and this sort of anecdotal information is backed up by evidence that nicotine itself may act as an antidepressant drug, that nicotine affects the cholinergic system through acetylcholine. There have been clinical studies that have shown that if you use a nicotine patch among non-smoking people with depression, that you can actually reduce symptoms of depression. And sort of chronic levels of low chronic administration of low levels of nicotine and block the acetylcholine reactors, which may be part of the impact, or that may be a part of the effect of low levels versus higher levels of nicotine. It's not just nicotine, it's a whole host of other nicotinic type drugs that affect this system that have been shown in preclinical trials with I think it's rodents of some sort, at least, that in the models of depression among rodents, that nicotine directly impacts and improves symptoms of depression, along with a number of other of these nicotinic type drugs like mecamylamine, cysteine, varenicline. You may note that some of these other nicotinic molecules sound familiar, and that's because they are agonists in the case of mecamylamine, or partial agonists in terms of cytosine and varenicline. And cytosine and varenicline are both actually used as they're partial agonists that work to help people quit smoking, but they also can function as antidepressants directly, and they're affecting the same system. So that, again, there is good evidence suggesting that nicotine can be an antidepressant drug. The evidence for this goes back even further, of course, that even today, there is use of tobacco and nicotine as a medicine. And among many of the First Nations in Canada and Indigenous people across the Americas, there is current use of tobacco in order to treat a variety of different conditions. For instance, if you, most ceremonies involving ayahuasca, for instance, which has been identified as one of the psychedelics that used in traditional ceremonies in order, and has been shown to have pretty dramatic effects on mood and substance use. But those ceremonies often start with some sort of administration of tobacco. One of the forms of tobacco is called hape, or snuff, essentially, that it's a burned form of the sort of not the commercial tobacco plant, but the Nicotine rustica, which is the sort of the originally commonly used tobacco plant, which has much higher levels of nicotine, and it's burnt, and the ash is then used as a snuff, and it induces sort of a feeling of calmness and openness to the ayahuasca ceremony. And in general, that tobacco is known as sort of one of the most powerful of medicines. And again, this is another aspect of evidence that we should be taking seriously. Nicotine, of course, also has a number of physiological direct effects. We see with nicotine administration, increased heart rate, increased cortisol, which is a sort of an indicator of stress, and increased levels of blood pressure. These may be an indicator that the sort of the physiological response to nicotine is actually a stress response rather than a calm response. But in the case of depression, that kind of stimulant effect may be what people are seeking, at least on a short-term basis. We'll turn now to the evidence that nicotine and mental health are excuse me, are not sort of biologically related or physiologically related, but that the relationship that we see is really just a confounded one by other factors. And there is significant evidence of this, that we do see many different variables that are common to both. This, for instance, is a study that we did among 2S LGBTQI young adults. And this looks at the relationship between adverse childhood experiences and vaping and smoking. And what we see here very clearly for both vaping and smoking is that the more adverse childhood experiences somebody experienced, the higher the rates of vaping and smoking were. This is just one example among many. And one of the things notable about adverse childhood experiences is, of course, they come before either smoking or vaping, and certainly do have the potential to cause both the substance use and mental illness, and affect mental health among people as they age. Um, The other variables that could be important, of course, include poverty or experiences of racism, education, factors associated with where you live. There's more, for instance, tobacco sold in areas which have higher levels of poverty, which may be additional factor associated with the relationship. But we see this as sort of the common causes emerge over and over again. We did a study a number of years ago trying to get at this relationship. And here is sort of an image of the results. We took a longitudinal cohort, followed people from age 11 up through to the end of high school, and looked at not just the variables themselves and their cross-sectional association, but how they changed over time. We assessed the variables every 3 months over this period, so we could look at sort of closer at more real-time changes in mood and other variables that could be associated. And we use the technique to kind of build pathways. And here, for the relationship between depression symptoms and smoking, so these are people who we see the emergence of depression symptoms, and then later on we see the emergence of smoking initiation. We see one pathway that goes through stress, but even with 3 months, that was too long a period to be able to tell the direction between depression and the initiation of depression, initiation of smoking. So that's still could be a common factor. But there was one clear directional pathway that we saw. And that was where depression symptoms, seeing someone increase their depression symptoms, led to them later developing more friends who were smoking. And then that was associated with the increase in smoking. That is, that what we're seeing here is the potential of a social pathway. That is, as people become depressed, they start to change who they might hang around with. And in many cases, those people might be those who are more likely to smoke. And because they're around people who are more likely to smoke, then they start smoking too. That this is a social pathway, a real but a socially related pathway between depression and smoking. This slide is from another study, kind of looking at a sort of similar relationship. And here, what the big main point is that prevalence matters. That if there is this kind of social relationship, it matters how many people are smoking and what the characteristics of those people who are smoking. So in the study we did of the province of Ontario, people in high schools, that if we looked sort of among the general population, we saw a relationship between smoking and depressive symptoms among females and among females only. That is, that people who were smoking had higher levels of depression than people who weren't, if they were female. We saw no relationship among males. However, we divided the schools further, and we divided the schools by those who had high smoking prevalences and low smoking prevalence, where smoking was common and where smoking was uncommon. And common by gender. So where smoking was common among females or among males in particular. And when we did that, we found this relationship between smoking and depression emerged among both males and females, but only among schools that had low smoking prevalence. So where smoking was common, we didn't see this relationship. And where smoking was uncommon, we did. And one explanation for that fits exactly into this idea that friend smoking is sort of mediating the relationship between depression and smoking. That is, in places where smoking is common, becoming depressed doesn't really change your likelihood of where your new friend group may be higher levels of smoking. But in places with lower smoking prevalence, where there may be more comorbidities associated with smoking than it may have as well. And so, but and the final point from this is what it's clear to is that there is that smoking alone is probably not, it doesn't cause issues around mental health in everyone. If it did, we would see higher levels, higher prevalence of depression among populations that were where there was more smoking, but we don't. And that difference in a relationship, that effect that the relationship depends on how common smoking is in the population, that it may only affect a subgroup of the population, is an important one to note. Next, I'll turn to the idea that that nicotine can cause mental illness itself. That nicotine may, in fact, be impacting people's mental health directly. And as I've insinuated, it's really a challenge to understand the relationship between substance use in general and mental health. The factors are highly confounded. There are all sorts of variables that are of interplay. We have to tease out the directionality, which comes first. Is it nicotine causing, is it depression that comes first, or the substance use that comes first? And tease that out of sort of developmental pathways as well. And because there are so many different possible confounding factors, most of the sort of traditional study designs that we use are really lacking in terms of being able to make sort of causal inferences about the relationship. But there is one type of study that overcomes some of these issues around confounding and temporal relationship. And that type of study is called a Mendelian randomization study. And a Mendelian randomization design uses the sort of inherent randomness of genes, that their genes have all sorts of variation associated with them, and that variation can have stronger or weaker effects on a number of different conditions. And for something like nicotine, where we have both sort of broad genetic associations as well as specific genes that are associated with different aspects of nicotine use, we have some candidates to be able to assess the random distribution of genes within populations, and that will essentially work in the same way that a randomization works in an RCT, that it assigns people to different groups without them self-selecting into those groups. And this essentially controls for confounding in general. I'm over exaggerating a little bit, sort of the strength of the methodology, but in general, this is true. That this is of our potential designs, I would say it's probably our strongest possible one we have. And when we look at this to see if nicotine is a cause of mental illness, we see a number of conditions where it is strongly related. So the ones here, I think I would argue, are where we have sufficient information, except for perhaps anxiety. But the others, post-traumatic stress disorder, major depressive disorder, insomnia, schizophrenia, suicidality, suicide attempts and suicide intention, and bipolar disorder all show the effects that nicotine is a cause of mental illness for these conditions. There are actually a number of other conditions for which Mendelian randomization doesn't support. An important one is actually ADHD and ADD, where we see sort of strong relationships between smoking and those conditions, but those actually are not borne out by the Mendelian randomization studies that suggest that those are not. I think there's still a number of conditions, and further evidence is developing on those, as well as continuing to understand the relationship between the conditions here. The second reason, and I think very compelling to me, where we might understand that nicotine is a cause of mental health or mental illness, is by looking at what happens when a person quits. The reason that this is important is that many of the common causes, the idea that, for adverse childhood events, for instance, those happened, by definition in childhood. And when someone quits, that event doesn't happen again. And so we wouldn't expect a change in mental health to be associated with that change in substance use habit if the only relationship happened in childhood. And so for most, I would say, common factors, we can't correlate them to that moment of quitting or the time period of quitting. And so when we examine the effect after quitting, then that I think can be strong evidence. Many people know, of course, that in the short term, right after you quit, you don't feel very good. The period of withdrawal is sort of brings on irritability. But I think many fewer people, when you look know that when you look over the long term, and this is evidence from a recent Cochrane review of data that examines what happens after people quit among tens of thousands of clinical studies. And what we see is that when a person quits, they experienced increased psychological quality of life, increased happiness, decreased levels of depression, decreased levels of anxiety, and decreased levels of stress. Sorry. The magnitude of this association is approximately the equivalent of the effect that we see for people who are given antidepressants. So essentially, quitting smoking as an intervention has about the same magnitude of effectiveness as antidepressant medication. It's an incredibly powerful tool. And I think that this is a really urgent point for people, who, are many of whom are dealing with these very real issues and don't understand or don't know that they can improve their mental health by quitting smoking. But of course, that doesn't make sense. And we started with the idea that that the vast number of people who smoke report that they smoke in order to improve their mental health, and that they identify that that use of tobacco or nicotine is in fact improving their mental health, or both their mood and mental health conditions. There is clearly, and in general, we've seen pretty strong evidence for the idea that that people are using nicotine for self-medication, that it's very likely that there are common factors that are associated with both, and that nicotine is causing mental health issues in the first place. So how do we make sense of this evidence? How do we bring it all together? And my suggestion is to bring in the idea of the diathesis stress theory. And diathesis stress is it's sort of an idea that is used for a number of mental health conditions. And it is, simpler than the word sound. It's essentially the idea that substance use is related to, or substance use is, or any other stressor in the environment can cause mental health among a vulnerable population by sort of increasing the level of stress overall. And for that vulnerable population, that might essentially come over a tipping point, and that might induce a mental illness. So there are 2 points about this that are important to note. One is that this suggests that the relationship is one that is among those who are vulnerable, not among everyone who uses the substance. And 2, that it is about the stress associated with using the substance rather than the sort of the biochemical properties of the substance itself. And we can see how this might work. So for instance, let's take something that like doesn't have a biochemical component to it, or a pharmacological component to it. So say like something like a bubble bath. And the way that a bubble bath might work for sort of self-medication is that you're feeling bad. You say, hey, I'll have a bubble bath. You take that, you feel better. And then eventually at some point you start to feel bad again, and the cycle repeats itself. The problem when you move away from something self-care like in a bubble bath situation to a substance that has its own pharmacological properties, is that cycle can become magnified. And nicotine in particular is maybe really potent at this effect. The way that nicotine works as an addictive substance is different than a drug like cocaine or amphetamines, for instance. So if sort of the classic way of trying to identify an addiction for among mice, if for using cocaine or amphetamines, is that you have them a drug injected that is administered when you press a lever. We probably heard of these types of studies. And then you make it harder for them to get the drug. And so they have to press the lever more times in order to get that injection. And eventually you can get the rodents pressing that lever thousands of different times, and just in order to have that injection of the drug. If you do that directly with nicotine, however, and a number of different drugs, that doesn't actually work on its own. You can't just get rats to press a lever for nicotine directly. What you need to do is have that nicotine associated with a cue. And something else that is also gives some sort of stimulation. So and for rats, one thing that stimulates them, that they enjoy, is a light. So as you press the lever, you get both the injection of nicotine and the light that goes on. And once you pair those 2 cues together, that you start to see the development of addiction. And the way that nicotine works then is it facilitates how other experiences are enjoyed and used. So it's not just lights, but for instance, other substances that using nicotine together with caffeine, with alcohol, with cannabis, makes those experiences of those drugs more pleasant and more powerful, and more reinforcing of both those other substances as well as the nicotine itself. It's one of the reasons we see such high co-use of nicotine with so many different substances. But because of this reinforcement effect, then that cycle of self-medication becomes a cycle of despair, essentially. That as you are as you smoke or vape, you get your dose of nicotine, you may really experience the antidepressant effects of that drug. So you get both the experience of the drug itself and the pharmacological effects of essentially a small high associated with nicotine, but also the cues associated with an improvement in mood. Um, but what happens over time is that what you're only getting is that leads then to increased levels of dependence. So as you are trying to rely on the substance to improve your mood, you're also starting to get dependent on the substance. And as you start to become more and more dependent, what happens is you're no longer smoking for the antidepressant effects, but you're smoking or vaping for the feelings of relief from those antidepressant effects. And this figures essentially shows that relationship between those feelings of relief, the experience of time of withdrawal, the need to smoke again, and then the feelings of improvement after smoking a cigarette. So we have a really pernicious cycle here. We have a substance which may at some point have actually improved mood or improved symptoms of cognition or helped people feel better in many different ways. And that real experience of being helped is what made it easier for them to become dependent. And once they become dependent, then that cycle takes over, and it's no longer improving their mood, but making it worse, adding stress and making it worse. If we go back to the previous study I described on school children from age 11 through high school, we looked also at the other direction about people what happens after you started smoking. And here, interestingly, there was one clear pathway. That is, smoking led to increased levels of stress, which led to increased levels of depressive symptoms, sort of exactly as we would expect under the stress diathesis hypothesis. So that starting to smoke, as you become more dependent, you're actually increasing your stress. And that is leading to ultimately changes in your levels of depression and not in the way that you wanted them to. We can also see that that depression is different for those who are smoking specifically for self-medication. That among those who are smoking because they are trying to self-medicate, we developed a scale which put together a number of different factors which indicated people are self-medicating. And it was the people who were trying to help that over time started developing highest levels of depressive symptoms. And in a longitudinal way where it was very clear that was not depression causing the smoking, but the increase in smoking itself. So this diathesis stress then theory, I think, brings together all of the aspects and the confusion around the relationship between nicotine and mental health. That the relationship between smoking or vaping and depression is really facilitated by nicotine dependence rather than the substance itself among those who are most vulnerable. That this theory suggests that it is completely acceptable for there to be a relationship where acute use of nicotine does in fact act as a medication, that it may really help people, at least on short term when you're not, if you before you develop symptoms of dependence. But that the spirals of withdrawal and relief worsen mood and stress, worsen nicotine dependence over the time. And these pernicious cycles make it worse, in particular for those who are prone to self-medicate. And because the personal experience that it feels like this is helping, prevents people from quitting smoking, which may be the thing that long-term would help the most. So I've talked mainly about the evidence here for that really relies on not nicotine in particular, but the administration of nicotine through cigarettes. But for most youth who these days who are using nicotine, they gather that from vaping it rather than through smoking cigarettes. And so there are a number of differences, obviously, between vaping and smoking. Um, and one of them is the lack of other chemicals in vaping that there are the thousands that you would find in tobacco. Some of them may also have relationships with mental illness that, for instance, there are MAO inhibitors in tobacco that may have an impact both on dependence and on mental health directly that just aren't in the nicotine associated with vaping. Um, the other important thing about a difference is that the characteristics of the population are quite different. Vapors, for instance, actually have in many populations actually higher SES, and higher SES is certainly relative to those people who smoke. There are no and vaping can be popular, for instance, among people who play team sports, which is a protective factor for many aspects of mental health. So those sort of common factors that we see between vaping and mental illness and or other behavioral health issues are different for vaping and those issues compared to smoking and those issues. But of course, there is a strong relationship as well. And the important thing to note is that the diathesis stress theory suggests that it's not the substance necessarily that is causing the depression. The substance may actually be an antidepressant. The thing that it's doing, the reason that there's a link, it suggests, is that it's causing dependence. And that addiction is what is driving the relationship between poor mental health and vaping. So this is a study that we published recently that looked just at that among over 3,300 youth and young adults who are most of, and we looked among only those who were never smoking in order to get a sort of clean relationship about what happens among people who vape in particular, rather than sort of people who might use substances in general. And we looked at it longitudinally over the course of about a year and a half, again, measuring the effects every 3 months. And what we saw here is that the vaping dependence, but not vaping itself. So it wasn't the use of vaping or even how much you use, but whether or not you were actually addicted to vaping that predicted increases in depressive symptoms. So we looked longitudinally, not cross-sectionally, among never smoking youth. We also did not see a bidirectional relationship, that it was only when your vaping increased that we saw your levels of depression symptoms increase. But an increase in depression symptoms did not lead to an increase in either vaping or vaping dependence. And the data, of course, on vaping specifically compared to smoking is still new. However, we're starting to see the emergence of many of the same relationships that we saw between smoking and depression, from depression and anxiety, where the recent systematic review found 40 studies that looked at this association and found a strong relationship. A study on suicidality, a systematic review of 6 studies that, again, found a relationship. And we just completed here a number of reviews including one on sleep issues and insomnia. And again, finding the same relationship of issues among sleep that we saw for smoking among people who vape. And so there's every reason to suggest that these relationships and the sort of the causal reasons for them, at least particularly in terms of nicotine or nicotine dependence, will be the same for vaping as that you would see for smoking. And we see this relationship as well. We conducted an understanding this relationship, I think, is also important for interventions. So we developed an app called the Stop Vaping Challenge. And what it does is it encourages people to try try stopping vaping, and then provides feedback to them about how that process works, and allows them to kind of reflect on that process of quitting, and the process of the feelings of dependence that are particularly for vaping are often hard to interpret. And what we saw here's a sort of an example illustration, is that over the early in a quit attempt, you see a decrease in mood, and until about 10 days after, which is when the levels of craving are basically stabilize and go down. And after that point, we started to see increases in mood, improvements. And so getting people to understand that after a week or 10 days, there should start seeing improvements in mood associated with quitting smoking or vaping. And I think that this is really the most important takeaway, that people can improve. It is true, their experiences, and it is real, their experience, that smoking or vaping helps them improve their mood. But it is also true that that quitting can improve that even further. So the results overall of these studies suggest that there are bidirectional pathways between nicotine and depression, that sort of real social pathways that exist that link depression and mental illness to smoking and other substance use. That this antidepressant effect can in fact be real, but that quitting is the best way to improve those symptoms. Thanks. I'm happy to take any questions.
Dr. Shayton, we want to thank you for this incredible presentation filled with evidence and anecdotes as well, and the participation of all of you. So thank you all.